Hi and welcome to this review of the reproductive system, the anatomy from anatomy perspective. We will start with the female reproductive system and then we will move into the male organs afterwards in the next video. So if we start first with talking about the perineum is the area where the external genitalia and the anal opening will be located. And so we need to understand the boundaries of the perineum. And as you can see here in the picture, if we are to draw a diamond-shaped area here using anteriorly the symphysis pubis, and then on both sides we use the ischial tuberosities, and posteriorly we are using the coccyx as a point, then we are creating this diamond-shaped structure, and we call that the perineum. Perineum is important because, of course, there is sometimes you have infection or itching or burn in the perineum, which increases, of course, the staging of the burn. Anyhow, this is the perineum in the female, and this is the perineum in the male. If we are to draw another line that runs between the two ischial tuberosities, then we will divide this diamond-shaped structure into region into two triangles. Anteriorly we will have the urogenital triangle, and posteriorly we will have the anal triangle. The urogenital triangle anteriorly will contain, in the female, will contain the orifice of the vagina and the urethra, and in the male it will contain the base of the penis and part of the scrotum. Now the posterior triangle, or the anal triangle, will contain the anus and the external anal sphincter, as you can see here in the two pictures. And you can see immediately here that the perineum is much wider in the female because, of course, the pelvic outlet in the female is much wider to accommodate for childbirth. All right, we talked about this, the urogenital triangle and the anal triangle. So we're going to move now to the female reproductive system to get ourselves acquainted with the location of the organs. Let's have a look here at this sagittal section, and then we're going to talk about two pouches that we see, peritoneal pouches. So first of all, here's the uterus. This is a sagittal section through. Here is the uterus. Here's, of course, the symphysis pubis. Anteriorly we will have the urinary bladder, and from the uterus we will study the uterus later on, but for now this is the fundus, this is the body of the uterus, and this is the cervix, or the neck of the uterus, and that will lead to the vagina. The vaginal orifice is here in the perineum, as we discussed earlier. Now we're going to have the labia minora, labia majora. The urethral opening will be here in the vestibule, and then we have part of the clitoris also showing here. So what I wanted to bring your attention to is to two regions here, those little pockets that you can see here, and one of them is between the uterus and the urinary bladder, and that will be the vesico-uterine pouch. Vesico because it's the urinary bladder, and uterine pouch, and you can see this little peritoneal pouch or pocket here. Another pouch that's behind the uterus, and that's more important, it's called Douglas pouch or recto-uterine pouch. It's the pouch between the rectum and the uterus. There is a clinical significance in both these pouches because other than the fact that some surgeons rarely forget an instrument or a gauze or something that they were draining the blood with in these areas, in cases of infection, in cases of ruptured appendicitis or pancreatitis, these are the areas, because it's the lowermost point in the female pelvis. This is the area where pus and other infectious exudate will tend to accumulate here, and the doctors like to flush this if they can, because otherwise, if this becomes organized, it will lead to adhesions, and you don't want that. So these are the importance of important aspects of those pouches. Like I said, anteriorly we are going to have the vesico-uterine pouch, and posteriorly we have the recto-uterine pouch. All right. Um, Talking about the female reproductive system, the primary sex organ is not the organ of sex. It's the organ of making the gametes. The same thing in male. The primary sex organ will be the testis. Here, the primary sex organ will be the ovary. Everything else is secondary sex organ. So sex organs. So we will have the uterine tubes, the uterus. The uterine tubes sometimes are mentioned too as the fallopian tubes or the ovarian tubes. All of these names are correct. And from that point on, we will also have the uterus itself, and then we'll have the vagina, clitoris, mammary glands, although some books don't like to refer to the mammary glands as sex organs. Some do. Your book does mention them as secondary sex organ or accessory sex organ. In addition, we're going to talk about other glands that are associated with the vagina and the opening at the vulva. We're going to talk about those when we get to them. Okay, so first let's talk about the ovaries. The ovaries slightly larger than the shape of a diamond, and it is anchored to the pelvic cavity and to the uterus by several folds of peritoneum. We have the mesovarium, the broad ligament, the ovarian ligament, and the suspensory ligament. So let's have a look at how these ligaments look like. Here's the ovary and here's the uterus, and what we see here is folding of peritoneum that is covering on the posterior aspect the uterus, and it looks like a sandwich here, and then it goes, folds up, and then folds anteriorly in front of the uterus and in front of everything else, and that we call the broad ligament. You can see it here. Okay, now the broad ligament will encase lots of things, including the fallopian tubes, or what we call the uterine tubes, and will also encase the ovarian ligament, which we can see here. This is one of the ligaments that we talked about, one of the 4 ligaments that we talked about in addition to the broad ligament. So now we're down to 2. We have the broad ligament already, and we have the ovarian ligament. The ovarian ligament is a ligament that will connect the ovaries to the uterus. Now we have, we have 2 additional ligaments. If we look at the broad ligament, you will see here's the posterior aspect. We just made a section this way, and now you're looking at this section, at this plane. So you will have, here's the broad ligament, and the broad ligament anteriorly is going to fold, come anteriorly, pouches anteriorly to cover the ovaries, and then pouches again, turns posteriorly again, and then to unite again with the broad ligament. This kind of folding will give us this kind of mesentery, and if you remember, this is what we call mesocolon when it was attached to the colon, and so, but here it's attached to the ovaries, so we're going to call it mesovarium. So that's our 3rd ligament. The 4th ligament is the one we see here, is the suspensory ligament, and that will end up attaching the entire structure here, which is encasing the ovary into the pelvic wall. So these are your 4 ligaments. Again, here you have your broad ligament, and you have the ovarian ligament, you have the mesovarium, which is really the anterior folding of the broad ligament to encase the ovaries, and finally we have your suspensory ligament. Okay, all right. The structure of the ovary will be surrounded by cuboidal epithelium first, and these are called germinal epithelium. Underneath that, we're going to have a white connective tissue, and because it's white, we call it albugina. So we have the tunica albugina, and then deeper to the tunica albugina, then we will have the cortex of the ovary, and underneath the cortex we will have the medulla. The cortex will contain ovarian follicles, and the medulla will have the connective tissue, blood vessels, lymphatics, and nerves. Okay, so let's have a look here at the structure once again. So we have the germinal epithelium here on the way on the outside, and then we have this white connective tissue, and we agreed that this is called tunica albugina. and then we have the cortex that contains all these follicles, and we're going to talk about all these follicles in a little bit. And then the medulla will contain the blood vessels, the lymphatics, and some nerve supply. Okay? All right. So the ovarian follicles will mature, and but that's of course in the childbearing age only that there will be this kind of maturation, and ending with the menstrual cycle, as you all have studied probably in the physiology. So initially we have millions and millions of those ovarian follicles, and they are primordial follicles at this point. And then, but at birth, most of these are already dead, and from birth to puberty, even more will die. So at puberty, the woman will have approximately 200 to 400,000 oocytes that are still viable. And this is, of course, just an estimate. And those follicles will contain the oocyte, and the oocyte is the gamete. And initially, of course, it will be arrested in the first meiotic division. We may talk about that, although from an anatomy perspective, you don't have to know that, only in the physiology part. And it will be surrounded by follicle cells, and those follicle cells will change names according to the stage, and during that kind of folliculogenesis, or what we call the development of a follicle, is referred to as folliculogenesis. So the stages of folliculogenesis, or development of follicles, will go from primordial follicle into primary follicle, then secondary, vesicular, and then corpus luteum. And when the corpus luteum dies, it gives you a white tissue called corpus albicans. So let's have a look at them. Primordial follicle will have the primary oocyte, and will have follicle cells that are surrounding it. And those are simple squamous epithelium, or squamous cells here, not epithelium. And these will develop later on to make the granulosa cells. But right now, these are not granulosa cells, these are follicle cells and squamous follicle cells. So this is the primordial follicle, and this is the very initial step. Now, with every menstrual period, approximately 200 to 300 eggs will leave the primordial stage and then will join and will start to develop into becoming a primary follicle. Now, the difference with a primary follicle is that it starts to have layers of cuboidal cells, and we call these guys granulosa cells. We still have the primary oocyte here, which is, of course, the egg, and that will continue to mature further. And you can see here deployment of some other cells to form on the outside another layer other than this first layer. So this first layer will be the granulosa cells, and later on we will have another cell emerging, another cell layer here emerging, and that will be forming later on the theca cells. And the theca cells have very important physiological function, as we will learn in the physiology, and I will mention it quickly here as we go through. Then when the follicles are developing even further, they will become secondary follicle, and then they will have a fluid cavity inside. We call that fluid cavity, fluid-filled cavity. We'll call that antrum. And the antrum will divide. Because of this, the granulosa cells will divide. Some of them will surround the follicle itself, like you see here. Some of them will surround the follicle, and some of them will surround the egg. And the one that are surrounding the eggs here, these will be called the corona radiata, the radiating, I think star, corona, I think it means star. Anyhow, so here we have the corona radiata, the layers of granulosa cells that are surrounding the oocyte, and we have the rest of the granulosa cells here, and of course this is the antrum, this is the opening that is filled with fluid. What you will also see is between the egg, and this is the oocyte, and the rest of the granulosa cells, and you can see that here, which we call the corona radiata, you will see a transparent area. See this? And this transparent area is called zona, means zone. Pellucida means transparent. So you can see it over, once again, you can see it here, okay? So this is the zona pellucida. This part here is the corona radiata. This is the oocyte, and then we have the rest of the follicle, and here we have the antrum, and here we have the granulosa cells and everything. Okay? All right. So the vesicular follicle, then the oocyte is really getting bigger and bigger and bigger, and the space, the antrum, is getting bigger. So sometimes we refer to them, the mature follicle or the vesicular follicle as the Graafian follicle, and it will contain the secondary oocyte. The secondary oocyte will be surrounded again by the zona pellucida, which is the transparent zone surrounding the egg, and then the corona radiata, and then the antrum, and then other layers, as you can see here in the picture. So here we have the egg, and here is the zona pellucida. Here are the corona radiata, and here we have the rest of the granulosa cells. But we see here the establishment of this other layer, and you see it's very thick, heavy layer on the outside, and that will be your theca cells. Okay, so we have granulosa cells and we have theca cells. Okay, so if ovulation occurs and then the oocyte will leave, and leaving behind the granulosa cells, but the granulosa cells, which you can see over here, will become different at the stage where ovulation occurs, and they will change. They're not going to be called granulosa cells anymore. They will be called luteal cells, and they will start secreting progesterone and estrogen together. Only happens, primarily the progesterone happens after ovulation, not before the ovulation. Before ovulation, hardly. You have some progesterone, but hardly any. So anyhow, if this occurs, if ovulation occurs, then we have corpus luteum, and you see a picture here of the corpus luteum. Corpus means body, and the luteum is yellow, so it's the yellow body, and that will be very important to support pregnancy for the first 3 months or so, until the placenta has enough ability to support the pregnancy with its own estrogen and progesterone. So if we go back here, this if ovulation takes place, but if not all the eggs that mature undergo ovulation, most of the eggs, I told you that 200 of the eggs will enter the pool, 200 of the primordial follicles will enter to the folliculogenesis pool, only 1 or rarely 2 will undergo ovulation. If more than 1, then it's called superovulation, and that can be induced by drugs, which we use sometimes for in vitro fertilization because we want more and more eggs to ovulate, and sometimes we go in with a needle and pick those eggs up for IVF or in vitro fertilization. But what happens to the 99% eggs that did not develop and did not go through the entire process of making secondary Graafian follicle and then rupturing, giving us corpus luteum? What happened to those? Then they just regress and die by apoptosis, and we call that atresia or atresia. They just disappear and die, and they become connective tissue, and they get absorbed by the system. So not every primary follicle will develop into corpus luteum. Otherwise, we have 200 ovulation at the same time. Generally, we have 1, sometimes 2 ovulations in normal situation. I'm not talking about drug-treated patients, but in normal situation, we have 1 or 2 ovulations generally. Okay, so if pregnancy takes place, then that's fine, because in pregnancy we're going to have a hormone called HCG, human chorionic gonadotropin, and the HCG is going to stimulate the corpus luteum to keep secreting estrogen and progesterone, and that will replace the stimulus that the corpus luteum is getting from the pituitary gland. If pregnancy does not occur, then the corpus luteum, of course, is going to die, and it will become white, and that will call corpora albicans or corpus albicans, which means the white body, and it will just die, and then it will be slowly phagocytosed, or will become some connective tissue area or a little scar inside the ovaries. Okay, so these are the stages of folliculogenesis as described in your book, and here's a little table for you to summarize what we had. From developmental point of view, we have learned in biology that the meiosis will produce to you 4 haplotypes from one diploid cell. So we have 4 haploid cells from one diploid. That happens continuously in the male, but in the female that doesn't take place just like that. The primary meiotic division will take place, but the cells are not going to separate from each other. It's just going to duplicate. We have the sister chromatids, everyone is sitting together, and the division is not going to be completed unless the ovulation occurs. When the ovulation occurs, then the first meiotic division will take place, which has been arrested all along. So that is a very important thing to think of, that the ovarian cells have been arrested, I don't know, for 40 years or so in the first meiotic division, and then comes the time of the ovulation, then they will exit that arrest, that meiotic arrest, and they will continue their first meiotic division. The second meiotic division is not going to happen unless fertilization occurs. That's the signal for the second meiotic division to occur for you. All right, we'll talk about that more if you are to study physiology, or if you have already, then you know that the first meiotic division and the second meiotic division are far apart, and they don't necessarily have to happen. Many cells die, as I told you, 99% of the eggs every month die without undergoing the first meiotic division. They just are arrested in that phase, and the second meiotic division happens only if the egg becomes fertilized. Okay. So here's the process of oogenesis. Here we have the diploid cell, and then when it divides, then it will give us a primary oocyte. And the primary oocyte is not really a haploid cell. It still has the 46, but it's duplicated 46 chromosomes, and it stops there. It doesn't divide any further. It has what we call first meiotic arrest. Comes the ovulation, then the first meiotic arrest will be escaped, and the egg will finish its first meiotic division, and giving you 2 cells. Each of them will have 23 chromosomes that are duplicated. 23 chromosomes that are duplicated. However, in this division, one of the cells will take all the cytoplasm, and the other one will not have any cytoplasm at all. The one that will not have a cytoplasm, it's going to be called the polar body, or the first polar body, and the other one will take all the cytoplasm with it. This, of course, will die because it doesn't have cytoplasm to survive. And this one will continue, but it is arrested in the second meiotic division, and it's not going to escape the second meiotic division unless a sperm joins in, and that will complete the second meiotic division. So the 2 sister chromatids will separate from each other, giving you the second polar body and the egg, and now the egg is fertilized. So remember, the first meiotic division will be only completed at ovulation. The second meiotic division will be completed only at fertilization. Okay. So there are hormonal changes that take place in the reproductive system. We don't have to talk about this much. That's more of physiology point of view. We have the estrus phase, we have the progesterone phase, or the secretory phase, and that will lead to different stages of development in the folliculogenesis. It will also lead to changes in the uterus, and we're going to talk about the uterus a little bit, where we have the proliferative phase, and ending up with the secretory phase, and then the menstrual phase, where the bleeding occurs. So we're not going through too much details of this because it's If you hear meowing, that's my cat next to me. I'm sorry about that. She needs to be scratched. So this belongs more to the reproductive system physiology, not much of the anatomy. So we're going to skip through that and go to more anatomy with the reproductive system of the female. So we did talk about the ovaries and describe the ovaries as the primary sex organs because they are the producers of the gametes, of the eggs. But then we need conducting system to take those eggs into the uterus, and we call these guys the uterine tubes. Sometimes we call them the fallopian tubes or ovarian tubes. And these will be laterally extending from either side, from both sides of the uterus. And the secondary oocyte is generally fertilized here once after ovulation. When it's ovulated, it's going to be picked by the ending of the uterine tubes. These are called the fimbriae, and the ovulation will take place here at the uterine tube. So the tubes are about 10 to 12 centimeter in long, and they are covered from the outside with the mesosalpinx, and on the inside they're going to have columnar epithelium, but it's ciliated epithelium. So it has brushes that push the egg towards the uterus. That's where the beating goes. Okay, so these are the areas of the uterine tubes. We're going to see it in the next picture. So let's have a look here at it. We're going to have the fimbriae. We're going to see that here. The fimbriae are these little fingers that we see here, almost hugging and very close to the ovary. And that's very important because what they do is they create a current and hoping that the egg will get sucked into that current. It doesn't always happen. Some eggs just fall into the peritoneal sac and just get absorbed, but many of the eggs will be absorbed here and get sucked with this current that's made by the fimbriae into the infundibulum. This will be the infundibulum. This is the fimbriae, and this is the infundibulum, and we can see here the infundibulum. And from there we're going to get into the ampulla, and then we go from the ampulla into the narrow portion of the tube, and we call the narrow portion the isthmus. You can see it here. And then we have a uterine part that's part of the tube that is inside the uterine wall. That is the uterine part of the fallopian tube. So once again, we have the fimbriae, and then we have the infundibulum, we have the ampulla, we have the narrow part that we called the isthmus, and then we have the uterine part, and that will be constituting your ovarian tube. Now the ovarian tubes are suspended by the broad ligament, but once the broad ligament folds on it, it's not going to be called the broad ligament. This part here, which is supporting the uterine tube, we're going to call it mesosalpinx. Remember mesovarium, mesocolon, and mesosalpinx. So this is folding of peritoneum that is surrounding and sandwiching the fallopian tube. Okay. All right. The walls of the uterine tube, on the outside we're going to have the on the inside, I'm sorry, we're going to have the mucosa, and that will have, like I said earlier, ciliated columnar epithelium. Then we're going to have the muscularis. It beats up and it causes some peristalsis movement, and the peristalsis movement will help into the movement of the egg towards the uterus. And finally, on the outside, we're going to have the serosa. We'll have some connective tissue, and the connective tissue is going to be covered with the peritoneum covering, and that's why, of course, we called it serosa. If you remember the serosa, we will have serous membrane covering the tissue. If we don't have it, we called it adventitia. Okay. Alright, so, and here we are looking at pictures of the uterine tubes, and we can see here the ciliated columnar epithelium. And the ciliated columnar epithelium, of course, will act as brush to push the egg towards this direction. It will also act as a hindering for the sperms that are being sucked and swimming against the movement of the cilia here, in order for the more fit sperm to find a way into the ampulla to fertilize the egg over here. Okay? Right. So we move from the uterine tube into the uterus itself. And that is a pear-shaped and thick-walled. It's very muscular, has lots of smooth muscle fibers there. Because of course these smooth muscle fibers are important every month for controlling the bleeding and ejecting the dead blood and or the dead tissue and the blood accompanying it at the period. But also, more important, it is very important for pushing the baby during childbirth. So we will talk about the layers of the uterus later on. I wanted to mention this point to you. The uterus generally is angled anteriorly. I think we have a picture here. Here we go. So it's generally angled anteriorly. We call that anteroverted. In about 10 to 20% of the girls or women, the uterus is pointing posteriorly, and that is called retroverted. The importance of this is during pregnancy, the weight of the baby will tend to push the uterus anteriorly again, and so it will be corrected by itself. If it doesn't get corrected, that can pose a problem because the uterus will become upright like this against the vagina, and that can increase the tendency for miscarriage or spontaneous abortion. So the position of the uterus being laying anteriorly here, the weight point will be here and the weight axis will be toward this direction, versus if the uterus is in a retroverted position and the weight axis, the push axis, will be towards the exit, and therefore there is more chance for miscarriage to occur. That's what anteroverted and retroverted position of the uterus refer to, and the importance of it. Okay, so what does the uterus do? It's the site for implantation, not fertilization. The fertilization will happen at the fallopian tubes or the ovarian tubes, uterine tubes. Sometimes the fertilized egg will fail to migrate from the fallopian tubes into the egg, into the uterus, and instead will get implanted in the fallopian tube. And if that happens, then we have what we call tubal pregnancy, and that of course terminates badly by severe hemorrhage and severe abdominal pain and a rush to the ER because pregnancy was in the wrong place. It's not supposed to be in the egg. But anyways, if it is in the right place, and that's what happens in 99 point something %, then it is at the uterus, inside the uterus. So the uterus is the site of implantation. It will support the developing embryo and fetus, and then finally it will help in ejecting the fetus during labor. It has lots of musculature that will help in pushing the baby out. Okay, regions of the uterus, sort of the same kind of regions we learned about when we talked about the gallbladder. So we have the fundus, the body, isthmus, and cervix. So let's look at those. So if we are to draw a line between the two fallopian tubes here, anything above that will be the fundus. So if I am to, from the opening of this tube to the opening of that tube, anything above that will be the fundus. Anything below that will be the body. But then we also have an area here that is the neck, that's protruding through the vagina, and we call that the cervix. So this over here will be the isthmus. We agreed that the isthmus will be the narrowest point in the uterus, as much as the isthmus here was the narrowest point in the fallopian tube. So we can see here the isthmus, here is the body, here is the fundus, and here is the cervix. All right. The uterus needs support, and the main support will be by this guy, the transverse cervical ligament, also known as the cardinal ligament. In addition to that, we have the broad ligament. We learned about the broad ligament earlier. We also have the round ligaments, and the round ligament doesn't really do much. It connects to the anterior surface of the uterus, and it will passes through the inguinal canal, and it will get inserted into the labia majora. But it helps into keeping the uterus anteverted, meaning the uterus leaning forward all the time. That's pretty much what the round ligament does. It doesn't offer much of support. The cardinal ligament, however, is where most of the support relies on. Then we have also uterosacral ligament, and the uterosacral ligament will connect from the name the uterus to the sacrum. And in addition to that, we have muscles in the pelvic floor, and that will hold the uterus in position. In the early times when women did not know about exercise after giving labor, and when women were giving labor after labor, that weakens the support weakened the support for the uterus, and then the uterus can start falling down through the vaginal wall in what we call uterine prolapse. Luckily, the incident of this happening is getting much less by time, just because of the education, and because less women now are getting 10 and 12 and 15 babies, and the fact that women know the importance of exercising the pelvic muscles, the pelvic floor muscles, especially after repeated labor, and the enhancement of health care and the follow-up of the women to diagnose any problem or any tear in that pelvic support of the uterus. The blood supply for the uterus is coming from the uterine arteries, which are branches from the internal iliac artery. By the way, the ovaries are getting two branches. One of them is from the uterine artery, and the other one is straight from the aorta, and we call that the ovarian artery. The testes also get a branch from the aorta, and we call that the testicular arteries. So, but anyways, the uterus is receiving its blood from the uterine artery, and the uterine artery is emerging from the internal pelvic arteries. Okay. If we look at the walls of the uterus, we have the perimetrium, and that will be a layer of connective tissue. It's a serosal layer of connective tissue. Serosal means it has peritoneum covering on top of it. Then we have the myometrium, and these are thick layer of smooth muscle fibers. We have the endometrium. These are composed mucosa composed of simple columnar epithelium and underlying lamina propria, or the connective tissue that's associated with the mucosa, and that will be filled with uterine gland. Now the endometrium will have layers as well. So we'll have a layer that is the basal layer that is capable of self-renewal. We call that stratum basal. Basal means basal, and stratum is layer. So stratum basal, and then we have another layer, and that is the one that keeps proliferating and keeps shedding as well. That's the part that gets shed. We call that the functional layer, or stratum functional. So we have, of the endometrium, we have two separate layers. One of them is the basal layer, that will be stratum basal, and the other one is the stratum functional, that as you can see here, that gets shed. In your book it's mentioned as stratum basalis and stratum functionalis. In the other book I was reading is stratum basal and stratum functional. Either way, it's fine. So we have the basal layer of the endometrium that's capable of renewing the endometrium, and then we have the functional layer that keeps multiplying and getting thicker and bigger and moving from proliferative phase into the secretory phase. And that's also the area that can be removed either naturally by menstruation or by curettage, when the GYN would go in with a curette to remove the endometrium if it fails to shed on its own. So that's a minor surgery that can be done in the outpatient clinic. All right. So here are the layers again. So we have the layers of the endometrium. We have this layer here will be the stratum functional, and then underneath it will be the basal layer or the stratum basal. Underneath that, we're going to have the myometrium, and at the very end here we will have the epimetrium or the perimetrium. Sorry, the perimetrium, which is really the peritoneum and some underlying connective tissue covering. The uterine cycle, it belongs more to the physiological aspect and the function of the uterus more than the anatomy, but the uterus will undergo changes, and the changes are induced by the estrogen, initially the estrogen, and that will induce what we call proliferative phase, where the stratum functionalis will multiply and get bigger and thicker, and then when ovulation takes place, then the uterus will be under the effect of both estrogen and progesterone, and the progesterone will cause glandular changes, so it will cause more glycogen secreting glands and more blood vessel formation. And if pregnancy does not occur after the pregnancy phase, then we will enter into the menstrual phase, where the functional layer of the endometrium will shed along with the blood. Everything will go down, and of course the stratum basal does not shed out. And the first day of the period is the day of the menstrual phase. This is how things are calculated to know when ovulation takes place and so on. So the first day of bleeding is the first day of the period. Okay. We don't have to know the details of this because it's more of physiological components that we don't necessarily have to learn as studying the anatomy or the hormones that are regulating, although I did my PhD on these hormones, so we don't have to discuss it here when it comes to the anatomy. All right. Going south from the uterus, then we will talk about the vagina. It's a fibromuscular tube approximately 10 centimeter in length, and that will connect the uterus to the outside. It's thin, distensible. We need it to be distensible. Imagine a baby has to pass through it, and it's consisting of 3 tunics. And we'll have mucosa, the inner mucosa. Tunics means layers. So we'll have the mucosa, and that will be stratified squamous epithelium. We'll have the middle muscularis, and then the outer adventitia. And the opening of the vagina is called the vaginal orifice. And near the opening, there are folds of the mucosa that form a semi-barrier. It's not a complete barrier. It's half a circle barrier or a semilunar barrier, and that will be called the hymen, which is broken after the first sexual intercourse. Then we are moving into the external genitalia to describe the external genitalia of the female. We will have what we call collectively the entire area, we call it the vulva, and that will contain the mons pubis, which is really a pad of adipose tissue, and that is covered by skin, and the skin is covered by hair. And then we will talk about the labia majora and then the labia minora. The labia majora here is folding of skin that is partially covered with hair on the lateral aspect of it, and in medial to it we will have other folding, and that will be the labia minora. And the labia minora will have what we call the vestibule, and this is this opening here between the two labia minora, and that will hold the orifice for the vagina, also the opening for the urethra or the urethral opening. All right. We did talk about the mons pubis, and so here is the mons pubis. It's skin. Underneath it we will have adipose connective tissue, and that's anterior to the symphysis. The labia majora are paired, and their thickened fold of skin also has some adipose connective tissue, and then they are covered with hair partially. Only the lateral aspect is covered with hair, and they have sebaceous and sweat glands, and it's very homologous to the scrotum in the male. Now, there are additional glands that are present in underneath the labia majora, but we're going to talk about these glands later on. The labia majora also contains some erectile connective tissue, and we call that vestibular bulb inside here, and that contracts during sexual, not contracts, but erects and becomes engorged during sexual intercourse. And then we have the Bartholin gland, or the greater vestibular gland, that will be here, and then it will open towards the vulva, and that will help in lubricating the vulva during and before intercourse. All right. As I said before, there is a pair of glands, and they are on either side, here and there, of the labia majora, and that's what we call the greater vestibular glands. Also, we call it glands of Bartholin, or Bartholin glands. We will see only the external part of the clitoris. The clitoris is mainly internal, and we only see the very tip of the clitoris, or the glands of the clitoris, but then inside it's almost like a Y-shaped structure, and that will be attached to the symphysis pubis, and we call that the crura. The part that is hidden, that will be the crura, but the part that is exterior, that will be the glands of the clitoris. Those are the composition of the clitoris will be made by corpora cavernosa, and this is erectile tissue. We will learn more about the erectile tissue when we get to the penis counterpart, because it's pretty much the same kind of structure. Now, capping the body of the clitoris is the glans, is what is seen from the outside, and the prepuce of the clitoris is a thin fold of an external fold from the labia minora that forms like a hood-like covering over the clitoris, and we can see that over here. That's the prepuce, and the clitoris over here. Okay. So this was the external genitalia of the female. There isn't much. There are additional glands that are also in around the vulva. There is a paraurethral gland known as skein glands, are also situated there near the urethral orifice. So it's somewhere near here. And these can ejaculate large amount of fluid during sexual excitement. But that's pretty much what we need to learn about the external genitalia of the female. Then we will move into the last accessory sex organ, and that will be or reproductive organ, and that will be the mammary gland. The mammary gland is to produce and secrete milk. We have the acini of the milk, and the acini will be surrounded with connective tissue, and that connective tissue is pierced by long fibers that are coming from the fascia that is on top of the pectoralis major, and they will go all the way anteriorly to the skin, and that is known as the suspensory ligament. that suspensory ligament sometimes gets invaded by cancer cells, and that gives the feeling and the image of an orange peel with all the little dimples on top, and not dimples but little dots on top, and that will be known clinically as peau d'orange, which is the orange peel, which is a sign of invasive cancer. So anyhow, we have the mammary gland, and we have approximately 20 lobes or so of milk producing glands, and those will lead to ducts, milk ducts, and where they will open into the nipple, and surrounding the nipple will be the areola, which darkens after pregnancy, and it darkens for a reason, so it becomes easier for the baby to identify it and for nursing on his mother. So this is the anatomy as we described. So here are the lobes of the lactiferous glands, and these are modified sweat glands that started to secrete milk. We have other glands here around the areola, and these are sebaceous glands somewhere in the middle between milk and sweat, and these are very important. They secrete oily kind of secretion, especially during nursing, because it will keep the nipple from cracking. You need to keep the sort of like nature-given cream or oil to the nipple to prevent cracking during nursing of a baby. All right, so we did talk about the lobes, and the further you divide the lobes, you will get into lobules, and then you get to the alveoli, and those acini will be producing milk. Those acini or the alveoli will be surrounded with muscle fibers, and those smooth muscle fibers, they will correspond or respond to oxytocin, and oxytocin will cause the ejection of the milk. The production of the milk is caused by prolactin, but the ejection of the milk is caused by a posterior pituitary hormone called oxytocin. Now the milk will drain into the lactiferous ducts, and those will go into under the nipples. We will have slightly enlarged or widened ducts, and we call those lactiferous sinuses. The milk will sort of being stored there, and then it will be much easy release for the baby once starts sucking on the nipple during nursing. Suspensory ligament is clinically relevant and important because the suspensory ligament is what holds the breast firm in position instead of dropping. But the important clinical aspect of it is sometimes the suspensory ligament. These are connective tissue fibers. Like I said, they connect the deep connective tissue, the fascia connective tissue over the pectoralis major to the skin. It pierces through all the tissue of the breast, and if they get invaded, then they shorten, and if they shorten, they will pull on the skin, and like I said, they can cause this kind of feature we call peau d'orange, or the peel of an orange. And so this is pretty much what we needed to know. The mammary gland, by the way, is supplied by medial and lateral mammary arteries. The medial ones are coming from the internal thoracic artery, and the lateral ones are coming from the lateral thoracic artery. This is the blood supply, and of course we know that the breast has heavy lymphatics, and that's what causes sometimes cancer to spread to the regional lymph nodes of the breast. So I'm going to stop the online lecture here with the female reproductive system, and then we'll follow it up with another video for the male reproductive organs and the anatomy of the male reproductive system in the second video, so please do join for that second video. See you then.